welcome and thanks so much for attending the seminar today. I'm grateful to Sabine and Mustafa for inviting us to talk on this topic. As Sabine said, I'm Professor of Medical Sociology from University of Manchester, and I'm speaking with my colleagues Kelly Howells and Steph Gillibrand from University of Manchester and Matt Amp from Groundswell. I'll let them introduce themselves as we're sharing the spotlight as we go through the seminar. So I'll let them introduce themselves in due course. So just try and move this along. Okay, so just by way of introduction and outline, I just wanted to start by saying, very briefly acknowledging that the literature on digital health inequities raises various questions about how digital innovations may introduce or compound inequalities, and the degree to which individuals and communities are empowered or disempowered through digital innovations. And many have also pointed to the crucial importance of involving marginalised and underserved communities in order to understand inequities and also to design appropriate solutions. So in this presentation, we want to focus on the how-to regarding involvement of underserved communities based on our research, which is centred on experiences of marginalised and underserved communities. Specifically, we want to focus on key issues and learning from participatory methods that we've used in several adopted projects. And this seems important because these issues are commonly underreported and yet crucial for the success of research. So whilst we're presenting work from two projects in the context of digital innovation changes, the issues we feel are relevant to wider research as well. So first of all, Kelly and Matt will focus on healthcare access for people experiencing home during. We'll talk about a project exploring the views of marginalised groups on data sharing. Again, a project that we partnered with Groundswell and other community-based organisations for. And Matt will also say a little bit about a specific project at Groundswell about lived experience roles for research and issues regarding stigma in the context of work focusing on homelessness. So we also intend to offer some overall reflections on participatory approaches, and then I'll also say a little about some work in Greater Manchester to enable and enhance how we do research in partnership with local communities and voluntary sector. So just wanted to start by saying something about participatory research overall. So what do we mean by participatory research? This is an umbrella term for research approaches reflecting a core philosophy of inclusivity. So such approaches are based on partnership and joint working with people who are the focus of research, and a view that working in partnership with those with lived experience is essential for creating appropriate solutions for problems faced. And there are varied forms of participatory approaches, including models of public involvement that emphasise joint working throughout the research process and co-production. And the roots of co-production and participatory research are in community action and social movements, with a focus on collective action to achieve change and to address inequities. And one thing to say is that there are common values across varied approaches, and values such as sharing power, sharing knowledge and expertise, respectful relationships and reciprocation. And examples include action research, community-based participatory research, and these entail stakeholders working together through cycles of data collection, reflection and further action. So now I want to hand over to colleagues Kelly and Matt, who'll talk about our first project example. So over to you, Kelly. You'll just have to tell me to move the slides on.
I will. Thank you, Caroline. Yeah, so I'm Kelly Howells. I'm a research fellow in the School for Primary Care Research and also the Patient Safety Research Collaborative. And I'm presenting this research with my colleague Matt from Groundswell. And today we're just going to give you some just little insights into a project we worked on together over, I think it ended up being 3 years, which was looking at healthcare access for people experiencing homelessness during the COVID-19 pandemic. So next slide, please, Caroline. Okay, so I just thought I would just give a little bit of context as to how this research came about. So, for people who don't know, people experiencing homelessness have higher levels of comorbidity and shorter life expectancy than the general population. And that life expectancy, as you can see, is a lot lower. So, average age of death in England for a man is 47 and 43 for a woman. So, despite high levels of need due to um, earlier rates of death, but also increased multimorbidity in terms of general health, people experiencing homelessness have less access to healthcare. And this kind of directly relates to Tudor Hart's inverse care law. He was back in the 70s pointed out that those in need of healthcare who suffer often social, geographic inequalities are the least likely to receive it. And unfortunately, although he was the one to point this out in the 1970s, things haven't changed for groups such as people experiencing homelessness. So we wanted to look into this. Next slide, please, Caroline. So what did we want to know? So originally back in 2019, when we started to look at this, we wanted to focus in on how people experiencing homelessness accessed care in Greater Manchester. We knew there was some innovations in Greater Manchester trying to, I suppose, offer specialist care and access to people experiencing homelessness. So we wanted to see what was happening on the ground, if this did increase access, how it helped people experiencing homelessness access care, and also just the general barriers to accessing care. And by care in this context, we were specifically looking at primary care. We knew from some work that people experiencing homelessness, for example, often end up in A&E as a last resort because they can't get access to a GP. But back in 2019, when we started to look at this, one idea was, could digital interventions help? Could we maybe come up with something that would help people access care? But we didn't know if people experiencing homelessness, number one, would want a digital intervention, how this would work. Did people experiencing homelessness have access to a smartphone, for example? And we also wanted to know what healthcare professionals thought about this. So I've just put a little quote here from one of the earlier interviews we did pre-COVID, which just shows that actually there wasn't really an appetite for this. If anything, most people thought digital interventions, such as remote care, would actually exacerbate inequalities. So the general consensus was stay away from digital. Next slide, please, Caroline. But then COVID happened. And we were coming to the end of our initial, me and Matt, of our initial data collection for this. And I'd obviously been talking about, no, we don't want to do digital. And then the world changed and it changed for people experiencing homelessness as well. So the people experiencing homelessness, we found often would access drop-in centres at some GP practices that called themselves inclusion practices. So we're more flexible to help people experiencing homelessness, or they'd access it through clinics, maybe outreach clinics reached in put on in hostels, for example. And all the doors were closed, and people experiencing homelessness also then had to call and have remote consultations. We were particularly interested in how this would affect access to care and if it would exacerbate those inequalities. Now, I'm not going to go into the results of that research today, although we have published, which we'll come back to later on in the presentation about access for those publications for anyone interested. But throughout doing this research from when we started in 2019, we wanted to take a participatory qualitative approach. So when conversations started happening in the old iteration of the PSRC about doing this work, one thing we knew and agreed on is that we didn't necessarily have the expertise to do this. Although we'd done some research with marginalised groups, we'd never done any research specifically with people experiencing homelessness. And we wanted to, I suppose, access people with expertise or lived experience in this area who we could do this research with. So as Caroline briefly explained in the introduction, Participatory qualitative approaches involve people who have experience and expertise of the topic being investigated or the people being investigated. This can happen in different ways, but the important part of it is that it's co-production, so involved at each stage of the research. So even when we initially planned to do this research, we knew straight away that before we looked at how we were going to do it, what questions we were going to ask, we wanted to be involved with a charity that could help us do this, which is how we ended up getting in contact with Groundswell so that we could do this research together. Next slide, please, Caroline. So I think this is a great time for me to introduce Matt, who can give you a little bit of background on Groundswell and how we did this participatory approach together. So next slide, please, Caroline, and I'll hand you over to Matt.
Thanks, Kelly. Yeah, I'm Matt. I'm currently an in-reach health navigator with Groundswell, but I used to work in research for 4 or 5 years. And just to sum up what Groundswell is, I mean, there's a great strapline or like a sort of saying, know us and them, and I think that sums up the organisation better than anything else. And it's a lofty ideal, very difficult to achieve. And one of the things that I've really noticed as I've gone is it kind of cuts both ways. Obviously, the know us and them is talking about, there's lack of power dynamic. There's no professional worker and person experiencing homelessness. That those lines aren't drawn, but it cuts both ways in a way, because you can almost, if you're not careful, end up lionizing lived experience and say lived experience of homelessness, and sort of saying it's everything, and it really isn't. To do this job, you need to be compassionate, you need to be understanding, but there does need to be people with lived experience of homelessness amongst the workforce. With Groundswell, it's I think 70% of the workforce has had lived experience of homelessness at some point or another. But the organisation is basically split up into 2 different sort of strands. There's the homeless health peer advocacy bit and health promotion, which I now sort of work in that sort of side of things. And basically, we help people go to appointments and advocate for them, and basically promote health in day centres and other places where you find homeless people in hostels or whatever, or people experiencing homelessness. Sorry. And then the research side of it, which is where I was working when on the project that we were working with Manchester University. I think it was called the Manchester Patient Safety Project. I never quite liked that title, but it was an absolutely awesome project. It really was. And as an organisation, we the one thing I should say, that one of the most important things about an organisation like Groundswell is the progression. Basically working with volunteers or people experiencing homelessness, if you don't have the progression element to it, it's just exploitative. Basically, you're just using people, as it can become very cheap labor, but basically you're focusing on the journey of that person. And for me, it's been, I was frontline homeless myself when I found Groundswell, and I went into supported permitted work, and it basically ended up in full-time employment. And a lot of people don't want to do that. They want to end up volunteering full-time or doing whatever, but progression is a massively important part of it. The little health now hashtag is now, that was a project that is now no longer, but it is a sort of element. It's how basically health now, it's health for all, basically. Can I move on to the next slide, and I'll talk a little bit about what is participatory research. It's less power imbalance, easier to recruit participants, shared trust, empathy, and sensitivity. More like to be honest, signposting, whatever. But what this comes down to is basically working together. And why this project works so well, as I saw it, Caroline and Kelly, is that we trusted each other as organisations, and we learned from each other. And you trusted us to go out there, find the people, talk to them in the way that we did, and then we learned so much from you. And I mean, not as an organisation, we learned so much from you, but personally, I mean, I started that journey as a peer basically as what I would call a peer researcher, but I ended it basically feeling like I was a grown-up researcher, like I was a proper researcher. And it was my boss, Martin, who kept saying that to me, don't always lead with your lived experience. And so as well as organizations learning from each other, there are all these little personal journeys going on. If you remember one of the interviews we did with Steve, and he was street homeless when I interviewed him, and he ended up becoming a project officer doing the same job I was doing, and that you get those sort of small victories as well. But yeah, basically it's openness, it's trust, it's working together, and learning from each other, I think, as organizations. Because there's always this feeling with frontline, sort of frontline workers in this sector, that academics are kind of studying us a little bit, like we're in the zoo almost. But then we never got that feeling at all. It was always working together. We were always kind of swapping notes. I mean, the one thing that I really think was important was the face-to-face meetings that we had, and that we developed those relationships because we met each other. And I think, although the move to digital and remote research hasn't been the total disaster I thought it was going to be, and there are advantages to it, like cost being one of them, but also, you can talk to people who are agoraphobic, and there are other little victories from it. You should never ever underestimate the power of those sort of, sitting down face to face and getting to know people. I think, just massively important. But yeah, what we did basically, as an organization is, that signposting better connected to services. We know where people, can find help. So during these research interviews, someone might talk about something, and in my InReach job now, I'm told not to advise people. That's part of advocacy. But when I was a researcher, I could tell people what, where they could get help all the time. And although I do that to an extent now, I've got to do it very carefully, because we're not allowed to advise people. It's a very sort of nuanced skill that I am actually learning. But yeah, shared trust, empathy, and sensitivity, I think, are the massive points to make. Have I missed anything there, Kelly, that we talked about yesterday?
No, I don't think so. No, I think that's great.
I mean, I think that kind of sums up what Groundswell did and how we work together, basically as organisations. But basically, it was a great advert for participatory working in every way, shape, and form. I thought it was extremely positive. Both organisations learned a lot from each other and gained a lot, I thought, from that.
Yeah, totally. I agree. I certainly learned a lot from working with you, Matt. And I agree, it was an awesome project.
Yeah, totally.
Me too.
Yes, I think we can move on to the next slide there, Caroline. So, so I think, as I mentioned earlier, we have published together on this. So we published the protocol when we moved into COVID. So we had to reapply to do the COVID research, and we did that together with Groundswell and also some partners in the NHS. So we published the protocol on that. We've also published the results of that study in BJGP. And me and Matt also contributed towards a paper looking at the challenges and adaptations to, it's called Public Involvement, in that paper that we had to make in COVID-19 to enable us to do participatory research with people experiencing homelessness remotely. So if anybody's interested on reading about that, feel free to have a look at those papers or drop us an email. And that's great. I think I can pass over to Steph now for the data sharing work.
Excellent. Thanks, Kelly and Matt. And over to you, Stephanie.
Thanks. Hi, everyone. So I'm Stephanie Gillibrand. I'm a research fellow in the Centre for Primary Care. I came into this, we've put this in kind of chronological order, because really this project started just after the COVID pandemic, if there was a finite deadline around that, but in the latter stages of the pandemic period. And I think the important thing to iterate in the first instance is that this project was made possible and born out of those original relationships that Kelly and Caroline had formed with Groundswell. And unfortunately, Dan can't make it today because he's doing some field work, and so I don't think he's managed to find a spot to be able to present in, but I'm going to try and summarise. So this project was building on some of the themes that came out from their other piece of work. We wanted to do some work that explore the views of different marginalised groups, so not just people who have experienced homelessness, but other marginalised groups surrounding their views around their health data sharing. Next slide, please. So the background to this, and obviously it was super topical at the time and has continued to be really topical, and I know this group will appreciate that, is the kind of rapid transformation in relation to data sharing during COVID-19. There was all the things about the COPI notices and the extension of data. We had the introduction of the GM care record that myself and I know plenty of others had the opportunity to work with. And all of this really raised key questions around what does that mean for people's views on having their health records used for not only research, but also in practice and in other types of research settings that isn't just within academic institutions. Obviously, we know that health inequalities were massively amplified during the pandemic, and data sharing was really recognised as an important opportunity to be able to for the government to be able to do their strategies around the pandemic, but also looking at this kind of inequalities that had been produced whilst being mindful of data protection and the intricacies around that debate as well. There is obviously a huge breadth of research that exists around public views on data sharing. Obviously, Sabine was involved with the citizens' juries as well, was really important part of that. But typically, considering how broad that research is, there is not as much of it is inclusive of marginalised groups, and so we really wanted to pick up on some of that in the context of Greater Manchester. Next slide, please. So again, we did a participatory approach. We broadened it out. So whilst Groundswell were our partners on the project team, we had a bit of a wider focus as well. So we worked with lots of different areas of the voluntary sector. We had some local community groups in Salford. We had some groups that supported refugees. We had some groups that supported people with mental health issues from South Asian backgrounds. So we had a really big swathe of groups that we worked with because we wanted to try and capture lots of different perspectives in this research. And it's kind of centered around having this advisory group model. And I use that term quite lightly because, because it wasn't a traditional advisory group, perhaps as they usually run, but more fluid and more involved with the project team than I think sometimes they can be. So we co-produced our study materials with them. The participant information sheets was obviously really important because we had to be mindful about the different groups we were trying to reach. Also some work around the topic guides, and I'll talk a bit more about that in a moment, and actually helping to co-facilitate some of the focus groups. So we had lots of different settings and we did lots of different co-facilitation approaches to meet the needs of those different research settings and the different groups we were engaging with. Next slide, please. So just a bit about the topic guides, because I think this was some really interesting way of working. You know, from the early stages of the research project, it was quite clear that we're talking about something that was quite complicated, and we wanted to try and understand people's views towards how their health data was going to be used in research, and also in the context of the NHS, you know, sharing for their direct healthcare, but also in, you know, kind of wider health context, so social care, and also in other research settings. So, you know, we might have instances where we work with private companies who use data as well. So lots of different settings where health data can potentially be used. And obviously that means that it's then, you know, we have to try and explain to people what we're trying to get their views on. And it's a very abstract topic. I think people will agree with that. You know, when we think about data, what does that actually mean? So we had to try and come up with a clever way to ask people's perspectives on it without giving them too much information that it altered their perspectives, but also so that everyone could start on a level-ish playing field. Because typically what we found was some people were much more informed than others. And how do we have a a valuable conversation that's mindful of those dynamics, but so that everyone can contribute. So we came up with these vignettes and these kind of case studies around different circumstances where people's health data might be used in these different sorts of settings. And those form the basis of the topic guides. So we would tell people these little vignettes, and then we would ask them their perspectives on, you know, what do you think of that? How is this health data used? And we always started off with this broad question: what does the term data sharing mean to you, as a way of kind of getting an initial feeler for where people stood in relation to that. Next slide, please. So with the data collection, so we made those topic guides in our advisory group. So we had input from Dan and from Groundswell, but we also had input from our different voluntary sector partners as well. And so then when it came to actually doing the data collection, the people in that in the advisory group were then helping to use those topic guides in co-facilitating the focus groups. So for example, Dan and Kelly and myself, we did lots of different team ups on this front. We went to hostels and day centres to do some research and some focus groups with different people experiencing homelessness. So we did one women's only one, we did one that was mixed group, to really try and understand people's perspectives using those different studies. And I think what came out from it was really the power of using those vignettes so that people could speak about their perspectives without it necessarily having to reveal too much information about their experience. Personally, some people chose to, but actually it was quite a good way of providing some protective kind of anonymity to people's experiences. And we were really flexible in our study design as well. And I really want to emphasize this for doing research in spaces with underserved communities. It's so important to be flexible. You know, we offered the combination of interviews and focus groups, and people could choose whether they wanted to do either one or the other. We gave the option for online or face-to-face, and we crucially, you know, we went to them to do this research. And I think that really made a difference in terms of the insights that we got back. Because of that, we did have a bit of a longer data collection period than might be typical in other qualitative research studies, but it is important to build that into your timeframes. And again, that was because we were trying to target such a wide range of different communities. And largely we did get insights from people from these different communities. Next slide, please. So just some reflections from working this way. And you know, Dan and I have discussed this in preparation for this, so I hope he won't mind me speaking a bit on both of our behalves here. And this really just reiterates what Dan and what Kelly and Matt have already said about the trusted relationships and the ways of working. And I do think this story of the kind of legacy way of working with Caroline and Kelly and Groundswell over that longer period of time really gave rise to this research being so successful. And recognise the different expertise of different team members. You know, some people feel more comfortable with some things than others. You know, when I went into the day centre with Dan, I was so grateful that he was there to show me the way. And like, you know, so not only is it a connecting force between, you know, us and the researchers, but also for the researchers being comfortable in those spaces. And, you know, we were also really mindful of our position as a research team and how we could get reach amongst these different groups. And I think that's a really important part of what Matt and Kelly have already spoken on. And I'm going to hand over to Matt quickly to talk a bit about this piece of work that I think summarises the current debate and some of the things that have already been touched on around the language that we use when we're talking about the researchers in our research teams and their experiences. So if I say next slide, and Matt, if you're happy to give a bit of an introduction.
Yeah, basically one thing I just wanted to add as well is you know, this whole thing about you know, digital research or remote research versus personal research is you know, basically at the end of the day it took me, it was like a new skill almost. I had to learn, I had to sort of basically go back to the basics, and it took me a lot longer to get to trust people remotely. basically, because you sit down with people face to face and they trust you immediately, basically. But on the phone, it was a different skill, so you kind of had to teach yourself it. But yeah, basically. So could you put the next slide up, please, Stephanie, so I can just have a look at
Yeah.
Yeah. So do people with lived experience of homelessness who work in paid or unpaid roles in the homelessness sector experience stigma and discrimination? Most definitely. I mean, it was, my experience working on that project was an interesting one, because I kind of, like I said, I grew into the role of being a researcher, and that sort of glass ceiling of, and I always used to lead with, if you remember this, Kelly, I was used to kind of lead with my lived experiences, like, this is why I am, because that's what I felt like I had on the table that no one else had. So I'd lead with it, but that would define me kind of as a person. Yeah, in what circumstances is stigmatization experience? Who's experience working unpaid or unpaid experience too? Yeah, I mean, basically, it's very subtly as well in a lot of this stuff, and people with the best intentions sometimes stigmatize people by trying to help, and by not trusting people, by not giving them it's basically, like I put in the chat a second ago, secret to all of this work is ask the client and trust their answers and opinions. And it's by doing that, people wanting to help too much and having the answers for people. And this is one of the major ways of stigmatization and sort of discrimination happens, is actually from people meaning well, not meaning badly. Do you know what I mean? So it's a constant, like, asking people what they want and what they need, and those needs and wants change. The COVID monitoring project, as it was originally called, came about, turned into Listen Up, came about as a project because they wanted to find out what was happening with people experiencing homelessness on the front line because of COVID, but then very quickly realized that people experiencing homelessness are in crisis constantly. So these are questions we should have been answering. We should always be asking, basically, people, So yeah, I mean, the stigmatization happens because of a lack of asking people. I think, this is very much my personal, rather than the findings of the research here. This is very much my personal experience. It's just a lack of actually asking people what they need and want. And there's another sort of, I was talking about two things that Groundswell does, is homeless health peer advocacy and research. But recently, we've started actually telling people what their rights are as well, so they know how to access those rights. So, we've been thinking about it in terms of, let's help people access help, let's find out what they want. But recently, we've been thinking more in terms of, skilling people up to access and ask for what they're entitled to as well. Which, I think helps to fight stigmatization and discrimination. I'm freestyling it a little bit here.
That's fine, Matt. That's really good. I don't know if you want to say any more in relation to this last slide of Dan's, or, I mean, I think you've given a really good summary there.
Yeah, I mean, the glass ceiling thing, we see it a lot, and I basically believe that we're still not trusted as people experiencing homelessness, even in organizations like Groundswell. There's just a lack of trust because people who've been on the streets have talking, and there was someone who was great, they were really good at their job and really caring, who worked there recently. He said, I just hate it when people who've been homeless swear in the office. And I'm like, well, they're coming in off the street, and it's like, let's not try and create an atmosphere where people, and generally speaking, no one gives a flying F about it, but to be honest, but they don't, because that's not important. You're basically trying to make people feel comfortable as possible, but those sort of ways of communicating can bar people. They can produce a glass ceiling, and there aren't enough people with lived experience in management positions. But this is a journey, and it's been going on for a while. I think it started with a lot of tick boxing going on, and I don't have anything against tick boxing, because eventually that box is going to be ticked, and people start, it's basically realizing it works, it's effective, and then they do it because it's effective. So I've actually got nothing against it. You know, if it's being done for whatever reason, it will eventually be done for the right reason, you know.
Excellent. Thanks so much, Matt, for that really good summary. So that was just sorry, this was just the last slide with those recommendations that staff and volunteers should have choice over disclosing lived experience, which I think really relates to what you've said, Matt. And
Yeah, just very quickly, Caroline. I mean, all these words like trauma-informed, safe spaces, lived experience. You know, people put lived experience, but lived experience of what? We all have lived experience, but I think we fail sometimes to define what these words actually mean. Like a safe space is somewhere you are comfortable sharing stuff. You know, it's as simple as that. And it's like trauma-informed is, you know, they can become meaningless unless we actually take the time to define the words. This is a very quick aside. So little soapbox I've been getting on a bit recently. But
all really good points, Matt.
yeah.
So thanks so much for that summary of that piece of work, which is available as a report also on your website, isn't it? On the Groundswell website called It Comes Before Your Name, all about that experience of
Yeah. I think it was done with London University, wasn't it, with Andy Guys?
Yes.
Yeah, he's brilliant as well. So yeah, it's a really great bit of work.
Thanks so much, Matt. Okay, so I think it's back to me now to try and draw together some overall reflections from the examples that we've presented, and hopefully one of the messages that you will all take from today is the need for establishing respectful relationships that are crucial for building trust and successful ways of working as the basis for any project. I think in the examples highlighted, we took the approach that we were working as one team. So as Matt said, no us and them, rather than a divide between researchers and community members. And this obviously takes time to establish a sense of being a team, just as in any other context. I think reciprocity is so important in fostering a sense of team building. And obviously you've heard from some of the examples mentioned before by Matt. I know that me and other members of the university side of the team have learned a lot from Groundswell colleagues. You know, they've been able to signpost lots of relevant resources, share experiences from a wealth of other projects as well. And we've also tried to ensure that we give something in return in recognising that expertise, sharing our expertise in terms of research and resources as well. And one example is that we arranged honorary contracts to enable Groundswell team members to have access to the university library, IT resources, etc. And finally, the last part of the last example about that piece of work, It Comes Before Your Name, that Matt stepped in to present Dan's slides for, I think touches on some important issues around lived experience roles. And, you know, some of the points raised in that work resonate for me regarding wider experiences beyond homelessness. And there is a real need to take care that we're not leaving people to feel their experiences are used inappropriately or even commodified, I think, as some of the comments were reflecting in that work. So I think all of these reflections also highlight the need for training and resources for researchers to ensure that they're effectively prepared to undertake work using participatory approaches. And so this leads me on to say something about wider work in Greater Manchester relevant to all of this. So I just wanted to mention briefly the REN programme. This stands for Research Engagement Network and is shorthand for the purpose of the programme, which is to support integrated care systems to grow their local networks with local stakeholders and to engage people from diverse communities in doing this. And this is in recognition that we need more inclusive research to ensure we develop best evidence for tackling inequalities that's relevant to local needs as well. And the aim was that we would develop and test out approaches for involvement, engagement and participation in research to develop evidence on what works. And the programme has been divided into multiple stages for multiple funding calls, and we've worked together across Greater Manchester teams to secure the funding for this programme, including from being led from the integrated care system, but all the NIHR infrastructure, the Biomedical Research Centre, Clinical Research Network, the Core Technology Facility, and the Patient Safety Research Collaboration, and has been hosted by the NIHR Applied Research Collaboration in Greater Manchester. And crucially, with leadership from the VCSE voluntary community social enterprise sector, led by the Caribbean and African Health Network. So Charles Kwaku-Odoi led on behalf of Khan, and also as a main link to the Greater Manchester VCSE sector leadership group. And the programme, so far has included some work to map activity for engaging communities across Greater Manchester and partnerships with voluntary sector in order to highlight some of our gaps across localities. And the image on the right just shows one of those maps related to some of the early work that we did. So we held multiple listening events to hear from communities and VCSE organisations on what needs to change and how to improve how we engage with communities, especially marginalised and underserved, who are often left behind. And there's a link there to the, you'll find more about this programme on the ARC, the Applied Research Collaboration website. And there's a report that you can download and more information. But just also to say a little bit, this slide shows some illustrations created from some of the listening events that we held. And many you'll see are really highlighting similar issues to those we've been discussing today. So including the importance of trust and meaningful partnerships, rather than researchers parachuting in and extracting information that they want. And many of the VCSE organisations referred to previous experiences of this nature that they'd found damaging and also served to undermine inclusion and participation. And there were also various views on what we could do regarding capacity building to enable better involvement, engagement, and even participatory research. And one of the ongoing pieces of work has been to train and support community champions, as well as developing resources for researchers. So, and finally, I'm just going to briefly mention another piece of work led by Caribbean and African Health Network in collaboration with all the other organisations, to develop a respectful research charter based on that work within the REM programme. And this charter reflects many of the values we've mentioned at the beginning of this presentation, as reflecting the philosophy of participatory research, and also illustrated in the examples we've presented today. So reflecting values of community ownership, that communities themselves should be in the driving seat, and leadership for research, respect for community values. This means working with community experts and to learn from them, and taking time to learn. Embedding research in communities, forming long-term partnerships, as we have done with Groundswell, as we've illustrated today, using accessible approaches, using the right language, the right venue based on need, etc., and developing mutually beneficial relationships, and including reimbursement for time and expertise, and acknowledgements of that expertise, and sharing knowledge and skills as well amongst team members. Okay, so I just encourage you all to look at the ARC-GM website for the Research Engagement Network, and where you'll find some of these resources from the REM programme. So I think with that, I will just say a huge thank you to all of you for listening. Thank you to my colleagues, Stephanie and Kelly and Matt, for fantastic presentations. And we'll just open it up now for any questions and discussion. Thanks so much, everybody.